First, of course, I'd like to acknowledge and thank Davor for putting together what has really been an outstanding webinar series. This is, it's 9 o'clock in the morning in Phoenix, so this webinar series is how I've started my day for most of the past, however long this has been going on, 6 weeks, or 4 to 6 weeks. So it's my great pleasure to have the opportunity to speak in this series. And of course, thank you to the ISHR and JMCC as well. So this is our campus here in Phoenix. We've experienced a great deal of growth over the last 11 or 12 years. And these are our new beautiful buildings. But as Martin said, I was one of the early faculty hired, one of the founding faculty. So when you're first on campus, you get the first buildings. So this is where I'm housed over here. But it's been an exciting campus to be involved in and to be part of this growth here. So as Martin mentioned, my background and interest has really been rooted in hypertension as a background. And this is, of course, we know hypertension is a major risk factor for heart disease, and it's also highly prevalent. So in the United States, at least 45% of adults, so aged 18 or older, have a diagnosis or have a blood pressure that puts them in a classification as having hypertension. And so that's about 108 million Americans, adult Americans, who have hypertension, the majority of which, of course, are uncontrolled. Hypertension is, as we know, the leading risk factor for heart disease and stroke and kidney disease, and it can increase the risk of heart failure twofold. Associated with this increase in blood pressure, we see remodeling of the left ventricle. The heart becomes hypertrophied, and over time it becomes fibrotic as well. And while these early hypertrophy changes may be important adaptive responses, we do also know that this can set the heart on a path, on a trajectory towards dysfunction. The other thing that can happen is individuals with hypertension, not only are they at greater risk for cardiac events and progression of heart failure, but the outcomes are often worse. We have many drugs on the market now to lower blood pressure. And what we've been seeing sort of consistently is drugs that inhibit the renin-angiotensin system, so ACE inhibitors and angiotensin receptor blockers, consistently show to be protective beyond just their ability to lower blood pressure. They're shown to be particularly protective against some of the pathological remodeling that can happen in the heart as well as in the kidney and other systems. So specifically in the heart, so we think of angiotensin, the renin-angiotensin system as a major controller of our blood pressure and maintaining the appropriate, or in disease state, an inappropriate level of blood pressure. But we also know that there are tissue and local renin-angiotensin systems, and we're learning, we continue to learn more and more about the local contributions of these factors. So within the heart, of course, we have a variety of cell types. The two primary cell types that, at least that I think of in the heart, of course, in addition to the vasculature, we have the cardiomyocytes, which we know to be the contractile workhorses of the heart. And then we also have these interstitial cardiac fibroblasts. And they play an important role in maintaining the extracellular matrix and the structural integrity of the heart. But they're also obviously important and can be turned on and activated in terms of a wound healing response. In the setting of hypertension, so as I mentioned, we get this hypertrophy and enlargement of the cardiomyocytes. But we also see an expansion in the number of cardiac fibroblasts. So we see an increase in their number, and at least a certain degree of them are become activated, and we start to shift towards the extracellular matrix. Turnover starts to shift to favor deposition. And so over time, we see this increase in interstitial fibrosis, which of course can have negative consequences on cardiac function. and again, can predispose ultimately to heart failure, which we know to be highly prevalent. There are many factors involved in this transition from a fibroblast to a more activated state, and we commonly refer to this as a myofibroblast, but we know that this can be a spectrum of changes in fibroblast activation. But when fibroblasts are activated, they can become more highly proliferative. They can be migratory, and this is of course important in the setting of an infarct where we need to have a robust wound healing response, and we need these cells to migrate to that tissue. These cells, both in their regular normal physiological state, but then also in when they're activated, can regulate extracellular matrix turnover. So they're secreting factors that not only degrade the matrix, but also secreting collagens and other matricellular proteins that make up the matrix. And then importantly, these cells are responsive to factors from immune cells, but they also play a role in recruiting inflammatory cells. So these cells fibroblasts can secrete cytokines and chemokines that can help coordinate and navigate a wound healing response. Of the many factors, there are many factors that are known to activate these cells, including stretch, but then also angiotensin II has been shown to both directly act on the fibroblasts to produce its effects, and then also through angiotensin II mediated increased production of transforming growth factor beta. So, as I mentioned, drugs that inhibit the renin-angiotensin system, in addition to their ability to lower blood pressure, have been shown to have an ability to attenuate these these responses in the myofibroblast or the activated fibroblasts. They can limit or attenuate the conversion of these cells and can dampen their activity levels. And this is why these drugs, or at least in part why these drugs are so effective in protecting against this pathological remodeling. With respect to the heart, so I mentioned all of the work that I'm going to be presenting in this talk will be for studies that were performed in the spontaneously hypertensive rat, or the SHR. The SHR is the most widely used model of primary hypertension. So these animals early in life, between around 4 to 6 weeks of age, they start to develop increase in blood pressure. And then when we look in the heart, in an adult SHR compared to a normotensive Worcester-Kyoto rat, although the heart of the SHR is hypertrophied, there's no significant difference in the number of cardiomyocytes, but of course the size of the cardiomyocytes is larger in the SHR, and that makes up most of the mass contribution. When we look at the interstitial fibroblasts, though, we see a significantly higher number of fibroblasts in the left ventricle. I should also emphasize, because I live in a hypertension world, the ventricle that I care most about is the left ventricle, because that's the ventricle that remodels during hypertension. So in the left ventricle, we see an increase in the number of interstitial fibroblasts compared to a normotensive WKY. And this work was from the laboratory of Denis Dubois, where I did my postdoc. When we treat these adult SHRs with inhibitors of the renin-angiotensin system, so either an angiotensin receptor blocker, in this case valsartan, or an ACE inhibitor, enalapril, we see a significant reduction in the number of left ventricular fibroblasts, starting to approach the normotensive levels, but about a 30% reduction compared to control. And this was where I first started becoming really interested in, well, what's different about these cells that are in greater number and then that disappear. And this set me on this path that laid the foundation for the work I'll be presenting today, is what happens after we clear these cells. And we know what happens if we continue ACE inhibitor treatment, right? We know that we have an attenuation of pathological remodeling, we have an attenuation in fibrosis. But and that's, in large part, we've reduced the signal, we've reduced angiotensin II, this stimulus for this fibrotic remodeling. But what I really care about is, well, what's the consequence of those changes that were induced by ACE inhibition? And do they persist even after stopping treatment? And so that's what we set out to test. So the other disclaimer is all of the work today will be was performed in male SHRs. We're in the midst right now of repeating these studies in females, but I can't say if we will see equivalent effects. So again, we had adult, male, spontaneously hypertensive rats. They have established hypertension and left ventricular hypertrophy. There's a degree of interstitial fibrosis, but they're not overtly fibrotic at this point. So we're really capturing them before they reach that stage. And their heart function is normal. So we treat with enalapril for 2 weeks. This is a duration that we know to be sufficient to reduce the number of fibroblasts in the left ventricle. And then I washed out the drug for 2 weeks. The reason we chose the 2-week time point is after stopping ACE inhibition, after stopping the drug, blood pressure will rise over the next 7 days, and then it will reestablish a new set point over that subsequent week. And so by 14 days, we now have a blood pressure that is stable again. We also have confirmed that the renin-angiotensin system is now fully functional again from a hemodynamic perspective. So high salt, low salt, angiotensin receptor blocker challenges, they move in parallel with the rats that have never been treated. With respect to the heart, we've measured gene expression of components of the local cardiac RAS, and they are not different at the end of this washout period. So for all intents and purposes, these rats, at least from a pharmacological perspective, are not different. When we start our challenge with the nitric oxide synthase inhibitor, LNAME, and we did this for 10 days, and LNAME will produce a dramatic increase in blood pressure, and then also produce multifocal cardiomyocyte necrosis and inflammation within the heart. And so we looked at whether the hearts of rats that were previously treated with an ACE inhibitor would fare better. And so on the left, we measured proliferating cells, and this is a time course from 0 through 10 days of LNAME treatment. And then on the right, we see macrophage infiltration. And so in both cases, we saw over 7 to 10 days an increase in cellular proliferation and macrophage infiltration into the left ventricle. But in those rats that were previously treated with an ACE inhibitor, so again, not continuously, but a previous transient treatment with an ACE inhibitor, we see an attenuation of this response during LNAME treatment. So while there's still cellular proliferation and macrophage infiltration, the levels of this accumulation is significantly reduced. Looking at collagen deposition and interstitial collagen deposition, again, we see an attenuation of this response. Importantly, looking at cardiac function, so after 10 days of LNAME, we don't see it. These rats are not in heart failure by any means, but there is a reduction in cardiac output in the LNAME treated animals that was not evident in the rats that were previously treated with enalapril prior to LNAME. So this was our first evidence for us that we could confer that the ACE inhibitor treatment could produce changes in the heart that would confer protection against a future pathological stimulus. So then the question for me is any of this related to changes in the cardiac fibroblast response to this LNAME injury? So we've repeated these studies, added an age-matched control. And in this case, we treated with LNAME for 7 days. We wanted to capture a time point where we would still be seeing proliferation and at least recruitment of macrophages, or at least production of factors that would recruit macrophages. Importantly, when we look in a blinded fashion at the degree of infarct or injury within the cardiac tissue within the myocardium, we don't see significant difference. So what the differences we're seeing appear to be the response to that injury, and not because there's just less damage, although it is, you know, highly variable with LNAME. Okay, so we isolated the fibroblasts, we cultured them to passage 1. And first we looked at their proliferation rates. Cells isolated from the LNAME treated hearts were relatively hyperproliferative compared to control, and compared to those fibroblasts isolated from rats that were previously treated with enalapril. And so again, these, in both cases, this is an actively remodeling heart, but the fibroblast responses are different. Similarly, we saw a marked upregulation in collagen 1 gene expression that was attenuated in the fibroblast from the previously treated animals. And looking at chemokine production in the media, we see an attenuation of the production from cells that were from the rats previously treated with enalapril. So just to summarize the background that will lead to the data I'm presenting today, we now have evidence that the fibroblasts themselves appear to be different in their response to the injury. Specifically, when we isolate from the LNAME treated rats that were previously treated with an ACE inhibitor, we see a reduction in collagen gene expression, proliferation rate, and macrophage recruiting chemokine release when compared to the control LNAME. And also we see a mirroring of what we saw in vivo. So we see both in vivo and in vitro similar changes. So now we want to actually to dial in and see if there's a change, a persistent change in the genomic profile of cardiac fibroblasts from the left ventricle in hypertensive rats that were previously treated with an ACE inhibitor. So the rest of the data is going to focus on this study. So again, we treated with the ACE inhibitor enalapril for 14 days, followed by a washout period. We had 7 rats in each group. We isolated the cardiac fibroblasts and then subjected them to single-cell RNA sequencing. And just an important, this will be different from the data I presented before because we are not isolating from an actively remodeling heart, right? There's been no challenge in vivo. These are isolated from a heart at a time point that we know that the tissue-based RAS, at least from a gene expression level, is back to normal. And so for those of you who may be less familiar, although I think it's becoming much more common now, so single-cell RNA sequencing is a high-throughput tool that can evaluate gene expression changes on a cell-by-cell basis. So each cell undergoes a reverse transcription to generate barcoded cDNA, and that will allow us to track, this barcode allows us to track gene expression changes within a given cell. And so the goal was to determine the impact of pyrase inhibition on cardiac fibroblast subpopulations, and we'll use differential gene expression, and again, focusing on fibroblasts isolated from the left ventricle of the hypertensive rat. So this is a UMAP plot, and so right now all of the cells are colored by treatment status. And so each dot represents a single cell, and the cells that are, the dots that are colored in blue are from fibroblasts isolated from the prior enalapril treated rats, and reds from control. And so but the first thing we looked at was just overall, are the cells, when looked all together, is there a difference that we can see in our cells from enalapril treated rats? In terms of the distribution of clusters, overall there's a lot of similarity, except when we look down in this region here, we can certainly see an area of control rats that is not overlapped by enalapril treated cells. When we performed differential expression analysis to evaluate genes overall from the enalapril treated versus control, We saw a downregulation in genes related to extracellular matrix, so collagens and lysosoldase, myofibroblast, or these activation markers, downregulation in the expression of growth factors, inflammatory factors, and genes involved in cell cycle regulation. And so when we subjected this to pathway analysis, some of the as we would expect based on what we were seeing from a gene expression level, we see downregulation in pathways associated or biological processes associated with wound healing, collagen fibril organization, and extracellular matrix organization. Of course, the benefit to the reason we do single cell RNA sequencing is not to look at the overall changes, but how that affects different cell populations within our pool. And so for those of you who saw the seminar on Monday from my postdoctoral fellow, Dr. Alexander Garvin, this plot should look familiar to you. This is the now each cell, this is the same plot we were looking for, but now each cell is colored by the clusters that were identified through this software analysis. And these are how they are distributed in control compared to the cells isolated from the enalapril-treated hearts. The software identified 9 distinct clusters labeled 0 through 8, of which the majority fall within 0 through 6. So we can see clusters 7 and 8 collectively make up about less than 2% of the total pool of fibroblasts analyzed. And so we're going to focus we focus the analysis for the purpose of this talk on clusters 0 through 6. Again, they make up the bulk of the fibroblasts. If you have not had a chance to view Dr. Garvin's talk, I would encourage you to check it out on YouTube. What she did was went through the characterization of the different phenotypes for these subpopulations of fibroblasts. And we evaluated that based on differential expression of each cluster compared to all cells. So what is uniquely different in gene expression for cluster 0 compared to all other clusters? And she took us through that analysis. In the interest of time, so that I can have more time to focus on the impact of treatment, I'm just going to give you the bottom line. Basically, we had 4 clusters that really had what we could identify to be a distinct phenotype. Cluster 1, this is just the pathway analysis results. Again, she presented more of the data. Cluster 1 was enriched for pathways involved in wound healing, inflammatory response, collagen synthesis, stress fiber assembly, and a reduction in an expression of pathways associated with cell division. And we term this our activated cluster or subpopulation. Cluster 2 was really enriched in pathways associated with proliferation and cell division, and a downregulation of those genes and pathways associated with extracellular matrix and inflammation. And we term these our proliferative cells. Cluster 3 is really interesting because it shows a mix of enrichment of upregulation and downregulation of pathways involved in fibrosis, in extracellular matrix regulation, but a consistent downregulation in inflammatory, and as well as an up and down in inflammatory response. We term these are moderately fibrogenic. And then the last cluster that was particularly interesting was really characterized by a downregulation of genes. There were only 2 genes that were uniquely upregulated. We see a marked downregulation or a significant downregulation in genes associated with response to wound healing and collagen biosynthesis. We term these are least fibrogenic. So they seem to be least likely to be promoting a fibrotic response. Well, we performed pseudotime or trajectory analysis to see how these subpopulations relate to each other. And overall, looking at all of the cells, this was the result we saw. When I first saw this plot, so each cell is colored by the cluster number from the cluster analysis. And so when I first saw this, this was exciting because we had, based on the expression profiles, we had considered cluster 0 to be our least active, and cluster 1 to be our most active, and 3 falling between. Cluster 6 we had also looked to be an intermediate phenotype. And so although the analysis was done in an unsupervised fashion, it played out in a way that I might have predicted. Certainly not this pattern, but at least in terms of this trajectory, made sense. However, if we then colored the cells instead of by cluster number, but by treatment status, what we saw was this. And so all of the cells from the treated rats are colored in this teal, and from the control rats are colored in this salmon pink color. And so what we saw was this separation where we see a shift towards the left side of the plot for our treated cells, and to the right for our control. And so if we think of just in the control SHR heart, again, this was presented by Dr. Garvin the other day, if this is what the fibroblast from an SHR may look like, perhaps we have our proliferating cell population giving rise to 3 different states: this moderately fibrogenic, our activated cells, potentially by way of cluster 6, and then these cluster 4, 5 that may transition us into this lower activation state. The other thing that, of course, jumps out is that there are cluster 1 cells that are separated, now we know, separated by treatment status, and cluster 3s, and in all cases we have this sort of separation within cluster. So the next thing we did was look at differential expression based on within each cluster based on treatment status. So we found that there were a number of genes that were significantly up or down regulated within each cluster, but really this is a story of downregulation. And so the vast majority of changes are characterized by a downregulation of genes, and these are, again, focusing on clusters 0 through 6. So that was the first obvious thing. We're seeing this reduction in gene expression, and we see it's a differential impact across clusters. Of all of these genes, the only ones that were, there were only 24 that were significantly downregulated in each of these clusters. And then the other thing that jumped out to us is that there were clusters 0 and 6 that seemed particularly susceptible to the ACE inhibition. Focusing in just on genes related to extracellular matrix and matricellular proteins and oxidative stress or inflammation within each cluster. So this is the impact of prior ACE inhibition on these genes, and in each of the clusters 0 through 6. For the most part, we see a downregulation in the expression level of these genes, with the exception of cluster 6, where we see an upregulation in these genes. And then the pathway analysis, again, the pathways that were significantly upregulated largely fell in cluster 6, and these are involved in cell growth and wound healing. The remaining pathways we see more, and again, that's expected, downregulation of pathways, and these are involved in proliferation, oxidative stress, and wound responses. So then lastly, I just want to present how what are the proportion of cells from the isolated pools from each rat, what proportion of cells fall into each cluster. And again, the control data was presented by Dr. Garvin on Monday. Looking at cluster 0, this is again what we determined to be our least fibrogenic cluster. We see a significant enrichment in the proportion of cells from the treated rats that fall into this cluster, such that this is actually, this cluster makes up the greatest proportion of the total cell pool from our previously treated rats. Clusters 1 through 5, not too remarkable in terms of differences between the proportion of cells that fall into these clusters in treated versus control. But then when we look at cluster 6, we see a significant reduction in the proportion of cells in this in this cluster. And again, this was found to be an intermediate phenotype that, at least by trajectory analysis, places it as a precursor to the more activated cluster 1. So the last differential expression that I'll present is when we looked at, since this seems to be a story of a reduction in cluster 6 and an enrichment of cluster 0, how do these two clusters compare to one another? And again, we're not comparing the most activated cluster. We know this to be an intermediate phenotype, but how does that shift impact? And so we won't go through all of these genes. We'll focus on the pathway analysis, but looking at least some of the ECM genes. So these are violin plots. So it gives a distribution of expression of level of expression of the genes. And in many cases, although there's a significant downregulation in the gene expression, we also see an increase in the number of cells that do not have that we do not detect this gene. And so again, focusing on the pathway analysis, we see a downregulation, as we might expect, based on what I had showed you from the overall changes, a downregulation in the pathways involved in wound healing and inflammation. And so to summarize, excuse me, we see persistent changes in the fibroblasts from a transcriptional level, in the fibroblasts isolated from a rat that had previously been treated with an ACE inhibitor. We also saw what appears to be a differential susceptibility based on how these cells are clustered. Excuse me. Overall, this seems to shift to a less activated or a less fibrogenic phenotype. And then we saw a decrease in this cluster 6, which may be a precursor to cluster 1, and in an enrichment in this cluster 0. Again, these are, at the time that these cells were isolated from the heart, these are not an actively remodeling heart, so we're getting, so this is reflective of what the current status of the left ventricle, or maybe it may reflect the current status of the left ventricle at this age. So what does this tell us? What I think we can, this tells us is that angiotensin II may be essential to maintain a diverse and more active population of fibroblasts in the hypertensive heart. And when angiotensin levels are reduced during ACE inhibition, we see this shift towards a less fibrogenic resident fibroblast population. And based on what we saw in our in vivo studies, our contention is that this leaves the heart in a better position to respond to a future fibrotic stimulus. And this is certainly something we're further diving into right now. So of course I need to acknowledge, most importantly, are the people who did the work. This is a picture from our most recent Christmas party, including some current and past Hale Lab members, and maybe future Hale Lab members. So Karen D'Souza, not pictured, did some of the early foundational work. Alexander Garvin, again, who spoke on Monday, did a lot of the responsible for much of the data in the new data in here. And then the sequencing was done in collaboration with Matthew Hunchelman's lab at the Translational Genomics Institute, who share our campus. Matt and I have been collaborating for many years on this project. Josh is a PhD student, did the sequencing, and Matthew is the bioinformatician. And then Mary Lindsay, who's been a great collaborator in these fibroblast studies. So thank you, and I'm happy to take questions.
Okay, thank you very much, Taben. That was a wonderful talk. Before I start off with the many questions that we have in the Q&A part, I would like to ask you two questions. One is, this immediately reminded me of the preconditioning type of situation that we have when you do ischemia reperfusion. So when it's like you can, given the ACE inhibitors, you can precondition from changes that will come ahead with the pathology. So I was wondering what the link is. Do you know what happens when you inhibit angiotensin? What is the mechanism that's, is there a reduction in ROS? What's the signaling that's producing those changes in the gene expression due to the inhibition of the ACE?
Yeah. So that's a great question, and that's, I think, the biggest question that we're trying to address right now. We know a couple of things. We know we have evidence, and much of this from Denis Deblois' group, that we see an apoptosis of at least a percentage of the cardiac fibroblasts in the left ventricle. So our first thought when I first went through these studies is, are we just reducing the number of fibroblasts? I don't think it's just that. When we isolate them in culture, we can see they're different. So then that's the next step is what's changing. I suspect there's probably epigenetic changes that may be, again, maybe dependent on this sort of tonic angiotensin II stimulation, but that's really what I'm trying to get at now.
Okay, and a second question is, do you plan on repeating these type of experiments looking at gene expression, but after an insult,
Yeah, absolutely. I think that's, one of the things we're really excited about when we set out to do this, because of we were isolating from a heart that was not actively remodeling. I was worried we might not actually see a difference at all, right? So the fact that we did was really exciting to us. And I think that's going to be the important question for a few reasons, or your question is a really important next step is how do these differ in a remodeling heart? And are those subpopulations, do they play different roles? And how is that modified by treatment? So that's exactly where we want to go next.
Taben, Martin, do you mind if I just jump in with just one question, just before you start answering? I mean, I'm fascinated by this, and thank you, because this is all unpublished, as I understand. You're about to submit it, and I think you'll get in because I'm interested. But
can you
are you suggesting essentially that maybe there should be a population that should be given ACE inhibitors even when they are not hypertensive, or because that to me sounds like there, as Martin says, there is a level of protection potentially that you might see because you're getting this less fibrogenic phenotype, right? So
yeah,
is this like a statin? Are you suggesting that? Give it to people over the age of whatever, and
I'm falling short of making that suggestion. There was actually a small trial that did look at that. Malvani was looked at several years ago, and I'm blanking on the name of the trial, where they took, I think they were 18-year-olds who had two parents who had hypertension, and they treated them with an angiotensin receptor blocker for a couple of years, and then monitored them to look at whether they developed hypertension later. I should say, this treatment and withdrawal we've shown and others have shown that you can actually reverse to a certain degree the hypertension even after withdrawing treatment. And so that was what he was looking at with this trial. Does that delay the development of hypertension? And it did to a certain degree. I don't know that anyone's followed them to see if there's been any change in their cardiac events, right? So whether or not they develop hypertension again is one question, and obviously an important question. But the next question would be, if they do they still have better outcomes in heart disease? So that's it'd be interesting to find those people from that trial. And I always emphasize when I give these talks, I'm never advocating for people to stop their ACE inhibitor therapy, but I think this is a really nice tool. By withdrawing treatment, it's a really nice experimental tool to help get at some of the mechanisms by which these drugs are protective.
Perfect, thank you. Well, I'll go into the Q&A and read some of the questions. The first one by Angelo Calderone asks, can you please comment, I suppose, on the phenotype of a myofibroblast?
Yeah, so this is, I think what Dr. Calderone is getting at is there's a lot of factors that can, and I think this goes to, there's a spectrum of activation in fibroblasts. And so I kind of hesitate, although it's a commonly used term, fibroblast, I kind of gear towards this characterizing the phenotype based on their gene expression. So what we called our activated fibroblast, these were cells that had an enrichment or upregulation. I think our cluster 1 are activated, upregulation in a variety of genes that have been associated with activation. And so we had obviously alpha-spin muscle actin, but then also other cells, other genes involved in stress fiber assembly and an increase in collagen or extracellular matrix production. And that in Dr. Garvin's talk, she talked about some of those genes that were enriched in that pool compared to the others.
Okay. Junhee Soon asks, how stable and consistent to administrate certain amount of ACE inhibitor L-name in drinking water?
Yeah, and that's a great question. We're not measuring plasma concentrations. My background was hypertension, so we always were looking at blood pressure as a readout based on radiotelemetry, and that's although I didn't present any blood pressure data, that's always how we're measuring arterial pressure. So we see, what I can say is we see a very consistent and sustained, very little variability, match-rat variability in terms of the anti-hypertensive response to ACE inhibition, and then not a lot of inter-animal variability in the hypertensive response to L-name. But I'm certainly not measuring plasma levels, and we adjust based on changes in body weight and drinking a couple of times a week. So we try and keep it within a range, but it's a fair point.
Hey, Heinrich Stegmaier, could you comment or speculate on the role of kallikrein bradykinin system, how it compared to ACE inhibition?
Sure. Yeah, that's another good question. As we know, when we inhibit ACE, we see that ACE also is the same enzyme kinase that degrades bradykinin. And so some of the beneficial effects of ACE inhibition may be due in part to enhancement of bradykinin. The other flip side is with angiotensin receptor blockade, some of the beneficial effects of angiotensin I blockade may be due to unopposed stimulation of the AT2 receptor. So there's been this debate, are ACE inhibitors going to be better than ARBs and vice versa? For this prior protection data, the studies, we've currently only looked at ACE inhibitor. My other work in terms of vascular and cardiac regression of the hypertrophy with ACE inhibitors and angiotensin receptor blockers, we ultimately never saw a difference between the two. So I don't know, at least in those studies, how much of a role bradykinin was playing. However, looking at the fibroblast apoptosis response, again, this was work done in Denis Dubois' group, they did see a difference in the time course of apoptosis when comparing ACE inhibitors and angiotensin receptor blockers. And they had some evidence that suggested, at least for the ACE inhibitors, that bradykinin B1 receptor may be playing some of a role in that. But beyond that, I don't, ultimately I don't know. But it's an important question, and we are actually, in other studies, we are looking at potential roles of bradykinin in fibroblast activation, but those are not far enough along to comment here.
Okay, we have a kind of a methodological question from Kishore Putsmarty. How are the fibroblasts separated from myocytes? Were they cultured prior to single-cell sequencing?
Yeah, this is a good question, and I know my postdoc, Dr. Gravin, got some questions on this too. So we isolated our fibroblasts through preferential attachment. So we mince the cells in a digestion liberase media, and then we maintain them in culture for 3 days. This was for a couple of reasons. We wanted to cast a wide net and capture adherent cells. Ultimately, we care about extracellular matrix production and collagen production, so we wanted to capture the cells that may be involved in that. we knew going in, and we debated this a lot, as you can imagine, we knew going in, at least based on our prior work, that we still would be able to capture phenotypic differences. So we thought we wouldn't, you know, our concern was by culturing them, would they all just homogenize? And so we were very relieved and excited to see that that wasn't the case. But that's what we did. We plated them for 3 days to isolate, expand the population a little bit so we could have sufficient cells for sequencing.
If I remember correctly from Bobby's answers, Alexandra's answers, you mince the tissue.
Yes.
So
yes.
That you're not going to get any cardiac myocytes that survive anyway, pretty much, right? So to kind of answer Kishore's question.
Yes. And I should also say, and Bobby mentioned this as well, that these cells, after sequencing, we looked, they were negative for CD31, negative for CD45, so they're non-hematopoietic, non-endothelial, 100% collagen producing. So we were comfortable that we didn't capture any of those other cell types.
Ian Dixon has, do you think that fibroblast subpopulations differ among left ventricle and right ventricle, among left and atria?
Yeah, I do. Again, we focused on the left ventricle because this is the ventricle that remodels in hypertension. But the earlier work from Denise' group showed that they did not see this. Not only was there not fibroblast hyperplasia in the right ventricle of the SHRs compared to WKY, those cells also didn't undergo apoptosis during treatment. And that apoptosis story was the first thing that got us thinking, is there are subpopulations that might be more susceptible. And so I think, so we've been very careful to be separating off the right ventricle and the atria before isolating. So my hunch is that they would be different. Obviously, we haven't tested that directly.
Okay. Imran Masood, would the fibroblast response be similar in aortic stenosis or atrophic fibrillation?
Yeah, so I think in general, there's evidence to suggest that the fibrotic response in various models of injury would be different. And what I think would be really interesting is to be looking at how these different subpopulations may play a different role depending on the fibroblast stimulus. I don't know the answer to that, but I think it's a really interesting question. And, we don't talk, there are, the two clusters that both Bobby and I didn't talk about, but I can't believe they're not important in some way too. So I think all of these cells are probably, they're there for a reason. And I think it'd be really interesting to see how those shift, how these things shift in different injury responses.
I think that the next question goes on the same way from Mathilde Keck. Have you performed experiments in other hypertensive models like salt-dependent hypertension?
Yeah, good question. Not yet. So one of the things that we're interested in is looking at fibroblast populations in an induction of hypertension model. And certainly Jeff Molkatine and Onur Kistihak have looked at some of those in the Ang2 phenylephrine and seeing how those change. But we haven't looked at, so we've done some Angiotensin II infusion, but we haven't looked at other hypertensive models. And I'm not sure if you're getting at the reversal effect or an induction effect, but the answer still is, to both questions is no, not yet.
Okay. Imran Masood again, if you had used another hypertensive drug such as beta blockers, would you have seen a reduction in fibrosis? Beta blockers have anti-inflammatory effects.
Yeah, another good question. And I think it depends on what ultimately is the stimulus for these changes, right? And if it is related to the apoptosis of the cells, then I would expect we would not see this specific group of changes because beta blockers have not been shown to induce apoptosis in left ventricular fibroblasts. Is that to say that beta blockers aren't causing any changes in the fibroblasts? I don't know. I've never tested it. My hunch is that within ACE inhibitors and angiotensin receptor blockers, my expectation is we would see similar changes when we add in other antihypertensive drugs. I just can't speak to it yet. But absolutely, and I think beta blockers would be a really interesting drug to evaluate.
Okay, so the next question is from Richard Heads. How did you identify the initial fibroblast isolated as bona fide fibroblast? If you isolate non-myocytes from rat hearts, you get a mixed population, including tissue-resident macrophages, can differentiate into fibroblast-like cells. I would suggest that different clusters represent cells with different developmental origins, not necessarily cardiac-derived. Cardiac lineage structural fibroblasts express specific lineage markers like TNF, TCF21, etc. Did you check for different lineages markers in the clusters, including myocyte or non-macrophage derived?
Yeah, another really important question. So as I said, we know at least that we don't have CD31 positive or CD45 positive cells. Beyond that, we know that from a differential expression standpoint, we don't see none of those lineage markers like TCF21 are coming up as differentially expressed across any of these clusters. Of course, an important caveat for single cell RNA sequencing is we're only capturing the most highly expressed genes, right? This is very different, and we need to do this in parallel ultimately with bulk sequencing, next generation sequencing. But yes,
I guess, Taben, sorry to interrupt. I mean, I guess Richard's question is, can a macrophage, for example, within a 3-day period of your culture, transition into a cardiac fibroblast or myofibroblast-like cell? And I don't know the answer to that, but do you know?
Yeah, thank you for that interpretation. I don't know the answer to that either. But that's something I'll look into for sure. I don't know, in that period, would they no longer express CD45 or CD68 of their origin? I mean, certainly we know that those genes are not expressed in these cells. And so
I just wonder, it is an interesting question, conceptual. Yeah. And it's an easy experiment to do as well, I guess. You know, get some macrophages and stick them on a plate and see
in our culture conditions, do they transform?
Yeah.
Okay, Kishore Putsumarti, could you comment on whether you saw any difference in angiotensin II receptor levels and related signaling molecules in the different cell clusters?
Yeah, great question. And my love of the renin-angiotensin system, those are always the first things I check. The RAS components, those genes never appeared on our differential expression lists. So no, we did not. To the extent that those genes would be captured, we didn't see any changes across clusters.
Okay, Murikech Brick, which angiotensin II receptor subtype is implicated?
Yeah, another great question. We published a paper a few years back looking at, this was an angiotensin receptor antagonist, and looking at the cardiac fibroblast apoptosis, looking at whether we could, again, this is not necessarily what we're talking about here, but at least from to the extent that apoptosis matters, we looked at whether that could be blocked by AT2 antagonism, and it could not, at least for the interstitial cell fibrosis. So and because we're treating with an ACE inhibitor, so neither of the receptor populations are being stimulated, my hunch is that this is a lack of AT1 stimulation that matters. But again, that's my hunch based on sort of the collective work that we've done, that we haven't looked at. Again, those are questions we can look at in vitro.
Li Guin Wang, why culture fibroblasts for 3 days before the sequencing?
Yeah, and it was, as I mentioned before, this was we went into this sort of high stakes, high cost experiment trying to figure out how to, we weighed all the pros and cons. The plating was a way for us to enrich our pool for adherent cells. And then beyond that, we wanted to get a point where we would have enough cells that we could get a good pool fibroblasts for the single cell analysis, yet not go too far that we start pushing towards too much of a differentiation. And so we did a couple of early experiments just to see how many cells can we capture after 2, 3, 4 days of culture, and we settled on 3, where we thought we would at least have a large enough population. So that's where we settled for now, again knowing that the caveat that and I'm very careful not to say that I think these clusters exist in the left ventricle. The proportion of them, may not be exactly the same in a left ventricle versus in our culture environment. And so I'm very careful about focusing on what's different between treated and control here.
Okay, next question is from Maria Celeste Villabrille, who's from my lab. Hi, Celeste. Did you measure the ACE component expression in both experimental conditions?
And so by ACE component, do we mean ACE gene expression, ACE2? Is that?
I guess the signaling pathway for the angiotensin II signaling.
Yeah. So again, in the work that we did in the whole left ventricle, we did the bulk sequencing and showed that at least at that 14-day washout period, there's no change in no difference in any of the components of the tissue-based RAS, and these did not come up differentially expressed in these cell types. I know, I think that's probably the.
If I understand correctly, this is a question from Chandan Kadur Nagaraju. If I understand correctly, fibroblasts were cultured 3 days before harvested for sequencing. If so, culture conditions can activate fibroblasts, differentiate towards myofibroblasts? Yeah,
so and as mentioned in Bobby's talk, they were cultured on plastic, and so we know that that stimulus itself can start to activate. We list that we consider that both a potential limitation because we're not in an in vivo setting, knowing that of course as soon as you take a cell out of the heart and mince it up, we're no longer in an in vivo setting anyway. But we also think this may be also a potential advantage in our study, because you could argue that what we're evaluating is the different response of cells from a control heart versus a previously treated heart to respond to that activation stimulus. So it's possible that it's allowing us to tease out some of these differences to a greater degree because we're now activating them. So we think there's sort of a pro and cost, or pro and con. And again, I think as I mentioned and Bobby mentioned, we were worried that would serve to homogenize, and we still nonetheless see differential expression of things like these myofibroblast factors that are differentially expressed from one cluster to the next. So we are seeing this despite this culture environment.
Okay, Laura Summerfield, I was wondering what you think of the effects. The effects you saw are based on, is it secondary due to alterations in the systemic RAS, or rather on the local RAS system?
Yeah, good question. And I think it's actually, I think we're seeing changes due to the local RAS. I think the fibroblasts are much more responsive than the cardiomyocytes even. So when we did next generation sequencing, this data hasn't been published, but of just left ventricle from the previously treated and control, we saw actually, this, because there are multiple cell types and we can wash out some of those changes, we didn't see the same degree of change as we did when we focused in just on the fibroblasts. We see much more impact of the prior ACE inhibition when we just look at the fibroblasts. So I think that tells us a little bit that these cell types may be more susceptible to the impact of ACE inhibition. And I don't think this is secondary just to blood pressure lowering. And so I think there's an important component to the local tissue-based RAS here.
Okay, Maria Villaurigi again. Do you know what happens to the fibroblasts from normotensive animals with the same experimental treatment?
Yeah, it's a good question. I don't know. My contention has been that with hypertension we see this diversity and more activated phenotype, and so based on that, bias or my hypothesis, I would expect that we would see less of an impact of ACE inhibition. But it's a question that we're very interested in answering.
Sweta Kumar, ACE inhibitors reduce the fibrotic phenotype in left ventricle, but if the fibers have undergone activation, can ACE inhibition potentially reverse this fibrotic effect?
So yeah, I think this question is asking if we treated with an ACE inhibitor after established fibrosis, right? Experimentally, there's some evidence that that you can reverse fibrosis to a degree with ACE inhibitors. For example, if you treat an aged hypertensive rat that has more established fibrosis, I think the stronger evidence is that ACE inhibition slows the progression and the activation. But whether we can reverse that activated, I don't know. I think we're probably more on a prevention side versus a reversal, but it's a good question to ask.
George Talady, NOS inhibition is also known to activate the endothelin-1 pathway. Do you think an endothelin-1 antagonist pretreatment could also show similarities to ACE inhibition?
Yeah. So my lab where we did our PhD work, we did a lot of, not my project, but looked at endothelin antagonists and can prevent that hypertensive response to NOS inhibition. My hypothesis is that an endothelin antagonist pretreatment would not produce the same effect, because I don't think the effects we're seeing are L-name specific, right? And I don't think they're just secondary to L-name induced hypertension. And again, the single cell data we looked at, shows that these fibroblasts are different, prior to an injury stimulus. So my hunch is that we would not see the same persistent effect, but I don't know.
The next question is anonymous, but I would like to ask the same question, really. Do you think that the angiotensin 1-7 could be involved in the mechanisms? Have you measured the RAS receptor expression on your fibroblasts?
So we have not directly measured the expression. Again, it didn't come up differentially expressed. It didn't come up in the list of the differentially expressed genes across clusters, but we haven't measured it yet. And again, at the whole LV level, it was not, its expression was not different at the end of the washout period. Also good question.
Bruce Allen, which clusters do you think would predominate in the left ventricle from non-SHR rats cultured on a soft substrate?
From a non, another question about the substrate, and really important, and we think about this a lot moving forward to, how should we do this? And aside from a non-SHR rat cultured, we have to ask the question of how would the fibroblasts from an SHR, how would the proportion of those clusters different in a soft culture? My hunch in a non-SHR, although we haven't done that single cell sequencing, I think those cells are probably potentially less prone to activation. I think the important thing, when we talk about substrates that we culture on, as I mentioned, as soon as we take these cells out, no matter what we culture on, we're not mimicking that in vivo environment. So obviously anything we're doing will ultimately have to be validated and look back in the in vivo setting. Which clusters?
This is it. It's providing that the soft substrate actually prevents activation in the first place. I'm not convinced that we know this yet.
Yeah.
Okay, and the last question is from, because there's one from to Davor here.
No, I think Richard's referring to the macrophages.
Yeah.
Oh, great. Okay.
He's saying they definitely can differentiate in those 3-day periods.
So Richard, if you're still online, do they no longer express CD68 or CD45? Do they?
Yeah, Richard's still online here, so he may.
And I can certainly look up your work. But if that gene expression gets shut down, then please let me know.
So Richard, put the beer down and respond to this now.
And the last question is from Henrik Strixmeyer. SHR hearts remodel metabolically before they hypertrophy. What would you think the metabolic crosstalk between myocytes and fibroblasts would be?
Oh, really great question. And this is something that my postdoc is particularly interested in. She spent a lot of time looking at cardiomyocyte metabolic activity, and she's really interested in the fibroblasts in that exact question. So she'd probably be the better one to answer it. The one thing I will say, and we focused, or I focused for the purpose of this talk on the extracellular matrix and matricellular proteins, but the other two other major sort of pathways that are really downregulated in these rats that were previously treated with enalapril are pathways associated to oxidative phosphorylation and protein translation. And so we're trying to get a better handle on that. But you're asking a different question. You're asking in that prior to developing hypertrophy, would you think of a metabolic crosstalk? Yeah. And again, I think this is a question that my hunch when Bobby moves on and develops her own program, I think this is a question she's going to be really interested in. Is in that crosstalk. It's a little bit out of my.
Is Heinrich saying that the metabolic remodeling occurs before the hypertrophy takes place, or in other words, before the fibroblast activation? Heinrich is a metabolism expert.
Yeah, and I'm not. And what I don't know, and this is so, and Heinrich, I wonder if you know, does that, or I guess I'm curious, what age? And I wonder, is that prior to the fibroblast hyperplasia? So, really interesting questions, and I'd love to think more about that. And I think those would be really interesting questions. I wish I had a better answer.
So I think we have one last question from another anonymous spectator. It says, stress induced by culture dish and FBS is known to activate the fibroblast and make them go pro-fibrotic. Is it possible to sequence them without culturing?
Yeah, good question. And I think the answer is yes. I think Wolkentin's group has done that. Again, when we were going into this, we wanted to make sure we had a sufficient pool of fibroblasts. So again, like I said earlier, we think of this as potentially a limitation and an advantage, because we may be looking at how these cells respond to what could be an activation stimulus.
Okay, I think those are all the.
Richard's going to have to make us wait till he can give a talk.
Well, Richard, the program is full, but hopefully we will continue in some shape or form after the lockdown. So you can be first on the list.
That sounds good. So right. I would like to thank Taben for a wonderful talk and very good questions and solid responses. So I think this was very provocative talk, and makes us think on how this the importance of this inhibition, and how you said, Davor, I think I'm going to start taking ACE inhibitors as of now.
I'm not sure if Taben's recommending that.
Well, I mean, there's a little risk, but I'm not gonna suggest it.
No, I mean, thank you, Taben. On my behalf, thank you for a really wonderful talk. I have learned a lot, as I always do somehow. It probably shows how little I know, but actually today I know a bit about cardiac fibroblasts and I've learned a lot. So, and Martin, thank you for really wonderful sharing. You provide a lot of insight into this discussion as well, and I appreciate that, and thank you. Audience, thank you for tuning in again. Everybody have a nice weekend, enjoy yourselves, and then see you all hopefully on Monday.
Thank you very much.
Bye-bye.